Okay, good evening, everyone. I'd like to welcome you to tonight's webinar for TrackNet professional billing clients. This webinar is put on behalf of the billing company by Collaborative Practice Solutions. My name is Dr. Alan Bass. I'm a consultant with Collaborative Practice Solutions. Joining me this evening is the Managing Director of Collaborative Practice Solutions, Dr. John Juliana. Good evening, John.
Good evening, Alan. Good evening, everyone.
Nice to speak with you tonight, John. Well, tonight's webinar is the second in an ongoing series of webinars that we're putting on that's exclusive to just our TrackNet professional billing clients. There are these webinars along with consultations, along with conversations that you have access to. All of the consultants are exclusive to TrackNet professional billing clients. And tonight's webinar is really about going back to the basics. We want to just go back and cover some of the real common podiatry procedures that we see, some of the codes that we see, some of the common challenges that we hear about from our billers that they encounter when they're working with all of our TrackNet clients. Tonight's webinar, like all of our webinars, are being recorded, and all of you are in a listen-only mode. On the GoToWebinar pane, you will have the question box there. Please feel free to fill your question in, type your question in there. Both John and I will do our best to answer these questions live as we're going on with the webinar, and if not, we will be able to compile all of the questions and put them out as a questions document to all of our TrackNet billing clients. Some of the things that we want to do is work as best as we can for you. One of the tools that's available to you that is, at least for me in my office, has become invaluable more than anything else is the integrated patient eligibility tool. That tool, with just a very simple visual cue, will allow you to know whether or not the information that you have within TrackNet for your patient is current and up to date as it links from TrackNet to the clearinghouse. If anything that you have doesn't link up, it's going to give you that visual either yellow or red cue that will tell you that there's something incorrect. As a quick aside, as I was practicing just the other day, wanted to look up something about DME for a patient that was sitting right in front of me, and I quickly looked in the computer, and I noticed that we had the insurance in the wrong order, and I was getting a red dot on the schedule, and lo and behold, I find out that there was a change in the insurance, and we didn't know about it, and it was brought to the attention of the front office, and it was changed right away. So right there, with a quick visual cue before the patient even had a chance to leave the office, we were able to make sure we updated patient eligibility. And it's just a really great tool, allows for really getting the information up to date before that patient even hits your door. You could check on eligibility the day before. You could do a batch eligibility. Just a really great tool. One of the other things that really helps our billers help you is moving over to our cloud-based software. I know a lot of you for many years have been on servers and have had the data right there. As you know, servers get old, servers need to be replaced. Unfortunately, with some of the natural disasters we're having with hurricanes, servers can go underwater, and allowing our billers to access your data via our cloud-based software will just allow them to work more quickly and much more efficiently than needing to go through those RDP type connections, which slows them down and really hinders them from doing the job as efficiently as they can for you. So really what we want to do tonight is really just come back to the basics, go through some of the most common podiatry billing things that we see, and it's stuff that me practicing still in my office that I do on a daily basis. It's great to have these refreshers. I can't even begin to tell you, even up until recently, how I realized that, until I really got to looking at some up-to-date LCD policies, that, you have to make sure you're using the correct codes more than anything else. So at-risk foot care is really one of the largest parts of our podiatry practices. And no matter if you love to be in the OR all day long, let's be honest, a lot of the nuts and bolts of what we do in our practice is at-risk foot care. And although the requirements are going to change a lot of from whether you're here in New Jersey where I am, or in Florida or in California, most of the basics are really going to remain constant. And it's really important for you to make sure that you have those completely up to date. So there are 7 at-risk foot care codes. You see them listed there. There are 4 as they pertain to nail care, 3 as they pertain to hyperkeratosis care. Nail care requires, as we all know, more than anything else, the main thing that it may require is class findings, some type of different class findings as opposed to circulatory manifestations, dermatologic manifestations, and those are always needed, especially when we talk about hyperkeratosis care. But when you're talking about nail care can have those Q modifiers that will tell you that there are class findings, but you can also have pain as a diagnosis for mycotic nail care. But callus care, hyperkeratosis care, those always will require class findings. That pain is definitely not a diagnosis in and of itself that will allow you to treat patients for their hyperkeratosis care. There must be a class finding for that as well. According to Medicare, remember, you must be 61 days apart. No matter if patients sign ABNs and put on modifiers, the G modifiers, the GAs, the GYs, whatever modifier, the only way that it's going to truly be paid on a regular at-risk foot care basis is when it is 61 days apart. 11.720 and 721 are going to be for the debridement of fungal or mycotic nails. 11.719, normal or non-dystrophic. G0127, the trimming or cutting of dystrophic nails. And 11.055, 56, and 57 is debridement or paring of corns and calluses.
Alan, if I could interject something
sure.
here, since you mentioned an ABN, and we did cover this on last month's webinar, all about ABNs. So if you weren't in attendance, listen to the recording of that webinar. We'll make sure that you know exactly where to retrieve it. But with those at-risk foot care codes, what we strongly recommend you do is each and every time the patient comes in, get them to sign an ABN. And the reason is you never know when a patient, for some reason or another, may have seen another podiatrist in the interim of that 61 days. And that will cause your claim to be denied, and you will not be able to bill that patient unless you have an ABN on file. So each and every time, get in the habit of signing an ABN.
Thank you, John. It's a great thing for you to just put in place, making sure that you especially with the TrackNet scheduler, knowing that you could color code, knowing when patients are coming in for nail care or at-risk foot care, making sure you always have that ABN handy for a patient to sign off when they come in to see you for that day. Most insurance companies will not cover routine foot care, and to be very honest, many years ago I stopped using the term routine foot care. Nothing that we do in our practices is routine. So when it comes to treatment of mycotic nails, any nail care, hyperkeratosis, this is at-risk foot care. The patient needs to truly be at risk in order for that care to be covered by whether it's Medicare or almost all other insurance companies. Systemic conditions such as diabetes or PAD, PVD would put that patient at risk and would qualify them for that care. It's very important that you do your best to work with your patients to make sure you have their primary care physician's name. You can look up through TrackNet. You can search for doctors' NPI numbers if that's needed. And then you must have that date last seen within 6 months in order for that claim to be properly adjudicated for that at-risk foot care, especially by Medicare. So making sure you have the primary care's name, the NPI, and the date last seen within 6 months is paramount in order to getting that covered.
And Alan, I'd like to interject again, and this
Sure.
is again something we covered on last month's webinar, but it's important when we're referring to the date last seen. We are seeing rejections now if the date last seen does not match the computer systems of CMS for a claim that had been sent in from the primary care physician. Years ago, we used to be able to just ask the patient, well, approximately when did you last see Dr. Smith? And you can give an approximate date. Now the computer systems are being more diligent. There has to be an accurate date last seen. And I know that creates a lot of hardship, but it does necessitate a call to Dr. Smith, ask them when the last time the patient saw them. And remember, that call only has to be done once every 6 months, and that would be sufficient. But the date has to be accurate to the day.
Yeah, I can't begin to tell you, John, how many times, you hear doctors have said over the years, I usually put in that, they said, they saw the doctor 3 months ago, and they'll put a date in from 3 months ago, and claims got paid way back when, and now the computers are getting much more modern, and they're getting caught up with that. So we do see those denials coming in real quick. So those at-risk foot care codes, those Q modifiers for class findings, the Q7 for an amputation, Q8 for 2 pedal pulses missing, and for Q9, the skin changes, diminished hair, temperature changes. So it's very important for you to make sure that you use that proper Q code. Just be diligent to that. I can't begin to tell you how many times I even see the improper use of that Q code that doesn't go along with the proper coding. Mycotic nails, 11-720 and 721. 11-720, up to 5 mycotic nails or 6 or more. Your primary diagnosis for either one of those should be onychomycosis. If the secondary diagnosis would be pain in foot or pain in toes, remember that there is no Q modifier needed. It's not at-risk foot care in that respect, and pain can be used for that secondary diagnosis when treating mycotic nail care. For obvious reasons, you know that you cannot be billing 11-720 and 11-721. I can't begin to tell you how many times both John and I, have seen some careless mistakes where doctors are billing both of those codes at once. And insurance companies are not just picking a line and paying it. They're denying the entire claim outright, and then we're having to resubmit these claims. So it's very important for you to realize exactly what you're doing. For your at-risk foot care, remember having that secondary diagnosis of PVD, diabetes with PVD, PAD. It's very, very important that you make sure you get that proper coding associated with that. Just to get a quick look at what some of the screens would look like within TrackNet, if we focus on the upper of the upper image. Medicare doesn't require that Q modifier because for that mycotic nail care claim, you'll have B35.1, but your secondary and tertiary diagnoses are both for pain. It's always required to have the referring provider on the claim details screen within TRACNet. However, depending on whatever state you're in, the supervising provider, I can't tell you whether or not that is the same person or if it's necessary based on the policy within your state. But Medicare, you could see, is the insurance carrier on this claim, and the guidelines here that would allow for pain as a secondary diagnosis to mycotic nail care. In this description in the upper right, you'll see that in addition to B35.1, you'll see that this patient has the diagnosis of diabetes and atherosclerosis, necessitating the use of the Q modifier, showing the patient to be at risk. And in the middle left-hand image, you'll notice both the referring and supervising physician is filled in along with the date last seen. Very, very important to make certain that is filled in, and it goes right on that claim details screen itself. Non-dystrophic nails 11719. Again, using that Q modifier in making certain that you have some type of at-risk foot care as that primary diagnosis. Of course, no mycotic nail diagnosis here, so B35.1 won't be seen here. But usually PAD, PVD, diabetes, things like that will be your primary and sole diagnosis on these claims. But that Q modifier and that date last seen showing that it's an at-risk foot care code is always going to be necessary for these claims themselves. GL127, trimming of dystrophic nails, any amount. So you'll see that PVD, diabetes, again, may also be used as a primary diagnosis. And the Q modifier, along with the date last seen by the primary provider, also needs to be within 6 months of the date of this service. One of the things that we have been seeing more and more, and all of you get a report from me once a month, known as your virtual practice optimization analysis, and one of the things that we're always looking at is 11721. And we know that code is really under scrutiny and under audit. And one of the things that we have noticed, and I've noticed in my practice for many, many years, is the use of 11720 with GL127, the use of 11720 with 11719 actually pays a few dollars more, $1, $2 more than actually using 11721. Number one, that will give you a much nicer distribution of your nail care codes across the board, keep you under that threshold, and keeps you away, hopefully keeps you away from audits for your at-risk foot care. And in the end, will pay you just a few dollars more than than just using 11721 exclusively. I know I've spoken with many of you over the last several months on calls, and some of you are starting to change your billing habits, and it's a good thing, because it's going to keep you away from those audits more than anything else. When it comes to treatment of corns, calluses, hyperkeratoses, remember that must be used with the Q modifier. PAD, PVD, is this is definitely an at-risk foot care code, and the use of pain is not a qualifying diagnosis for treatment of corns and calluses. And you can see that here on the screen. 11055, 56, and 57. Another series of codes that we do monitor for you on your VPO, or your virtual practice optimization report, each and every month. I will tell you that I look at those very critically, and look at the bar graph for each and every one of those on your reports, and I strongly urge each and every one of you to review that VPO report. You should be getting your VPO reports at the end of this week. All of our TrackNet professional billing clients will have theirs by the end of this week. It's a complimentary analysis that comes to you as a TrackNet professional billing client. Other TrackNet clients who are not part of professional billing pay several $100s each and every month just for this analysis that you receive complimentary. So 11055, 56, 57 as a primary diagnosis, L84 for corns and calluses, along with your at-risk foot care secondary diagnosis, PAD, PVD with diabetes possibly. Remembering those Q modifiers along with the date last seen with the primary care physician is required for payment of these. And pain, as I said earlier, is definitely not a qualifying diagnosis here.
Alan, before you go on, I just want to address a great question that just came in.
Sure.
If you can back up 2 slides, and this is something we covered on last month's webinar, but
is this where you wanted it, John?
No, the one before this. This is something we covered on last month's webinar, but it bears repeating because this is a frequent mistake as well. The question is this: do we have the 5.9 modifier in the wrong place here? Because according to CCI edits, Correct Coding Initiative edits, G0127 is column 2. The answer is yes and no. This is the one glitch in CCI edits. Whenever you have a 11720, the Q859 actually goes on the mycotic nail code, and the Q8 goes on the G0127. Completely contradictory to CCI edits. Even though one is valued higher in RVUs than the other, it's a mix-up in the system. It's been there forever. So anytime you have 11720, that gets the 5.9 modifier. I just wanted to make sure we answered that question, Alan.
And John, would you also say that in addition to the G0127 just getting the Q modifier, would the 11719 also get just the Q modifier?
Yep, same thing. It would be 11720 Q859, 11719 Q8.
Good. All right. Thank you for stopping. It's a very valuable piece of information for everybody. So some other common codes that we see, and we see some errors on also. So for treatment of ingrown nails, 11750, matrixectomy, the permanent partial removal or permanent removal of a nail plate. 11730, the avulsion of a single nail plate, and 11732, additional nail plates removed. We know that only the L60.0 ingrown nail is a required diagnosis. No secondary diagnosis is required. But what is required is the proper T modifier. I can't begin to tell you how many claims we're seeing denied. And John, would you say that the T modifier have we seen a lot of denials where they're using just the RT and the LT as opposed to the T modifier?
Absolutely. Yep.
So it's very important that you're using the proper digital modifier as opposed to LT and RT. We've seen that more and more, that insurance companies are really cracking down on making sure that the proper modifier is being used.
The common question I also get about T modifiers, Alan, is do the T modifiers, are they exclusively to CMS or do they apply to private payers as well? They most definitely apply to private payers as well.
Yeah. So with that, I am going to now turn this slide deck over to you, John. I'll advance the slides for you since I have them on my end, and take it away with the rest.
Yep, absolutely. Thanks, Alan. So last month we talked a lot about the different modifiers that unlock the keys to payment. So again, please go back and watch those if you didn't see last month's webinar. But one of the things we are now seeing very ramped up are audits for 25 modifiers. So it bears again repeating that if you're going to use a 25 modifier, you need to understand what the 25 modifier means. We still see lots of doctors, both our clients and private consulting clients that we have, using 25 modifiers with at-risk foot care, with routine use of the 25 modifier each and every time that patient comes in. Please understand, the 25 modifier means that you have a separate diagnosis that warrants the need for a repeat of what you did on your initial exam of this patient, the evaluation and management. You have to have that separate diagnosis, or there has to be, if it's the same diagnosis, either a subjective or objective change in the status of that patient, which would warrant an entirely new evaluation and management and plan. That's the only time a 25 modifier is warranted and medically necessary. And what's happening is we're seeing these audits ramp up, and what those audits do is every time a 25 modifier is used, the carrier, Medicare, requires the claim to be dropped to paper, and enormous resources are being used. Rather than focusing on valid claims, your billers are focusing on dropping these claims to paper and sending them in by paper. So please be very careful. Doctors are being asked for money back. Alan, if you'll forward.
Yep.
Another thing I want to point out that we did not cover last time because this is rather new. Most of us do surgery. Most of us understand the global postoperative periods of surgery. If we're dealing with a bone surgery, for example, we know that there's a 90-day postoperative period, and most of us have fallen in the habit of just not entering any code at all for your post-op visit. Well, now what I'd like you all to start doing, and for certain states, if you're a practice over 10 providers, it's actually mandatory. Florida, Ohio, New Jersey, it's mandatory only if you have a practice of over 10 providers. But even if you don't, even if you're a solo practice, I'd like to have you start putting in the 99024 code, which is an evaluation and management service taking place within the global period of the surgery for the same diagnosis. So you're going to enter this into TrackNet. You're going to actually bill a zero charge for it. Now, why do I say do this? Medicare right now is monitoring the 99024 code because they are going to get rid of global periods. Maybe by next year, there will be no longer any global periods, and they're using these submissions to look at the fees being paid for your surgery. By submitting this, you're telling Medicare, hey, I need to see this patient every week for good clinical care. So hopefully that causes the actual surgical fee to go up. So get in the habit of entering 99024 with a zero charge.
John, before we go on to the next slide, really going back to almost what you were talking earlier about the 25 modifier, somebody asked a question about denials, and somebody wanted to know can you define a little bit about first pass denial rate? Talk a little bit about what we've been seeing with claims getting denied, maybe as it pertains to 25.
Yeah. So, often what will happen actually, there's two types of audits: prepayment audits and post-payment audits. Prepayment audits to me are much nicer because you're not getting paid. All it's doing is creating more work. Post-payment audits are very painful because that's where you're going to be asked for money back. The 25 modifier, or any modifier for that matter, is a license to unlock that key for payment. So we're often not seeing a denial when you use 25 unless it's a prepayment audit. But Alan, to the question about what is a first pass denial, first pass denials most frequently occur, and again we covered this last month, as a result of something wrong with that patient's demographics. In other words, the insurance is not active. You have something wrong with the Medicare number or the carrier's ID number. Something is wrong that leads to an immediate rejection at the clearinghouse level. That's the first pass, clearinghouse. We're not talking about it even making it to the carrier. You mentioned something before, Alan, which is instrumental in reducing first pass denials. Everybody should be using the patient eligibility feature. There's no reason for first pass denials. We strive, TRACNet Professional Billing strives to have a 2 to 3% first pass denial or less. Way better than industry standards. And that's how you help us, by using at the desk your patient eligibility feature.
Very good. All right, let's move on.
Let's dive into some wound care. We have lots of clients who do a great amount of wound care. This is really a subspecialty of podiatry that during my career really ramped up very nicely. All the data shows how podiatrists are instrumental in reducing amputations. So you have different levels of debridement when we're talking about wounds. And unfortunately, again, not just TRACNet Professional Billing clients, but even private consulting clients that we have, we see distribution patterns that just don't make sense. Medicare has data. They have epidemiological data that they will use against you. If you're debriding a wound that's only epidermis, you should be using the 97597 code. If it's up to 20 square centimeters, it doesn't matter how many wounds. It's the cumulative square centimeter of the wounds, plural, that matter. If it's up to 20 square centimeters, it's 97597. If you have wounds that total greater than a total of 20 square centimeters, then you would add 97598. That's the additional square centimeters. Now that's just for epidermal wounds. If you're debriding to the level of the dermis, same principles, up to 20 square centimeters, then you should be using a 11042. But if your data is showing all 11042s and no 97597s, once again, you're in a potential outlier situation that can trigger an audit. The additional 20 square centimeters would be 11045 for dermal level wounds. If you're debriding to muscle or fascia, 11043, with additional 20 square centimeters being 11046. All the way to bone is a 11044, with additional 20 square centimeters, 11047. Next slide, Alan. Injections are another very commonly encountered procedure in the billing company. I think by far the most frequently used code is a 20550, a single injection of a tendon sheath or ligament, most commonly used for plantar fasciitis. It is the injection for plantar fasciitis. But then we also see quite a bit of 201 injections or arthrocentesis aspirations of small joints. For example, if you're injecting the toe, 605, which is applicable to the
John, you're cutting out a little
metatarsal.
bit. Your phone was cutting out just a little bit there. If you could maybe just quickly repeat what you were just saying about the 20600 and 20605.
Yep.
Oh, it sounds like we're losing John even a little bit more there. So I'm going to jump in there.
Am I coming?
Oh, you're cutting in and out. So you still with us?
About now.
That's a little better. Go right. Let's try it again.
Yeah, I'm sorry. For those of you who know top practice, we speaking at the conference, so in a hotel room. So I do apologize. Is it painful?
You're still cutting out a little bit. So you know what? Maybe I'll take these slides a little bit. So let me jump in for you, John, so we don't keep cutting out. So again, as John was saying, the codes for the injections 20550, a single tendon sheath, most common use for plantar fasciitis, and 20600 and 20605 for aspiration and or injection of small joints. 20600 more commonly used for toes, and 05 is most commonly used for the ankle. And below, you're going to see the most common diagnoses. You'll see plantar fasciitis or plantar calcaneal spur. Other diagnoses, of course, are good for 20550. 20600, diagnoses for effusion or pain in joints. And in this case, when talking about the injections, the RT or LT modifiers are definitely required, where no secondary diagnosis is required on these. Let's see, John, are you back?
Let's give it a try. How about now, Alan?
Now you're a little bit better. Go right ahead, John. I'm going to take back
sorry. It has to be the hotel room that I am speaking from.
Okay,
please
go right
stop
ahead,
me.
man.
Please stop me again if I start to break up, Alan.
Okay,
so
sure. Go right ahead.
The common injection codes beyond what Alan just covered. For a Morton's neuroma, the typical Morton's neuroma, you should always be using a 64455. That is the proper injection for Morton's neuroma. We struggle a great deal with a destruction by neurolytic agent, 64640. This code should absolutely be paid, yet it is one of those codes that for no reason whatsoever, incorrectly, they're commonly denied. I'm not telling you not to bill it, most definitely bill it, but this is one of those codes for some reason carriers just hate. But 64455 definitely for the neuroma injection. And you should also be billing the substance that you're injecting, the J code. Alan, next slide, please. I put this slide in here not to educate about hammer toes and bunions, because clearly we all know the codes for arthroplasty and bunionectomies, and we know that there's a whole variety of codes for bunionectomies. But you'll see why I put this in here. The arthroplasty code 28285 is the proper code for the arthroplasty, and it's bundled if you're trying to bill both the DIP, the distal interphalangeal joint, and the proximal interphalangeal joint separately on the same toe. It's simply not going to work. That's what we call a bundled situation, and trying to unbundle it is undoubtedly going to get your claim denied. It's still one arthroplasty, even if you are addressing both distal and proximal interphalangeal joints. The other reason for this slide is that the arthroplasty requires a T modifier, not an RT or LT. The bunion requires the RT or LT, but you have to use the T modifier for the arthroplasty. Next slide, Alan. The screenshot is here for a separate reason. Notice how 28296 for the bunion procedure, the primary diagnosis M20.12, has the LT modifier. The 28285 has the T modifiers. Notice how the 5.9 modifiers are in place for the lower valued RVU procedure, which is the arthroplasties. Last month, we talked a little bit about how if this was a Medicare patient, you actually wouldn't use the 5.9 modifier. If you are repeating a same code, in other words, 28285 here is repeated 3 times, that would require an XS modifier for Medicare. Medicare only, not a 5.9 modifier. So that's why I put this screenshot there. Next slide, Alan. So you heard me use the word unbundling. One of the biggest struggles that we have is, and believe me, Alan and I both empathize with the fact that the more work you do, the more we should be paid for it. But unfortunately, correct coding initiative edits dictate what's included in a procedure and what's not. The best resource around, what I believe everybody on this call should be subscribing to, is the APMA Coding Resource Center, because there you can simply go in and look at these CCI edits. They will tell you for the hammer toe or for the bunion what's included there, what can you bill for and what you can't bill for. You know, we have doctors who absolutely, and we feel, believe me, we understand and empathize, they want to get paid for the extensor tenotomy being performed during that arthroplasty of a hammer toe. But unfortunately, that's unbundling. You could get paid for the metatarsal phalangeal joint capsulotomy, but you can't get paid for an extensor tenotomy. So that's the example of unbundling, and the APMA Coding Resource Center absolutely defines that very easily for a very inexpensive annual subscription. Let me jump into some DME so that we all are on the same page of some of the common misconceptions about durable medical equipment. As you all know, durable medical equipment is provided for therapeutic benefits. It's a device that is intended to last a period of time. There's really no clear definition of what that period of time might be, but a durable medical appliance is not something you would traditionally dispense weekly for a patient. In order to submit DME claims for a patient, you don't submit it to your traditional Medicare carrier. And you'll see shortly the jurisdictions of the DMERC carriers, as we call them. Also, you need to be separately credentialed to be a DMERC provider. And please make sure you do not allow your PCOS validation, which is part of the validation to become a DMERC provider. Don't allow that PCOS to expire. Unfortunately, we've had instances of clients, both private and TrackNet professional billing, where their PCOS letters that were coming to their office or their emails warning them that their PCOS was going to expire soon were completely ignored. It becomes a nightmare. It's a few-month process to get that revalidated, so stay on top of that. This is showing you your particular jurisdiction of where to send your DMERC claims to. It doesn't go to your traditional Medicare carrier. Next slide, Ellen. A couple of things about durable medical equipment to always keep in mind. Let's talk first if this is a Medicare or a Medicare Advantage patient. You must have the KX modifier for Medicare and Medicare Advantage plans. You must use that KX modifier. The KX modifier, again, is a key to unlock the payment, but you have a responsibility on your end. It means you are telling Medicare that you are compliant in all of the professional standards of being a DMERT provider, including things like providing the warranties and the signatures necessary on the provider standards that you have to keep on file. That's what the KX modifier means. Also for Medicare and Medicare Advantage patients, you must use an LT or RT modifier. You have to have an ordering provider. That ordering provider happens to be you. The place of service is home. The patient is using this device as home, in their home, for traditional Medicare. It's sometimes office for Medicare Advantage plans. You have to know, according to your location, according to your jurisdiction, because that does vary state by state. Next slide, Alan. If this is a commercial insurance, you do not need a KX. KX is only for Medicare and Medicare Advantage patients. So you don't need a KX for commercial insurance. You do still need the RT or LT. And while an ordering provider is not typically required, put it on there anyway. I've never seen it get rejected because you had an ordering provider. But most definitely for commercial carriers, you are not going to use home as the place of service. Place of service is office. Next slide, Alan. So some of the common DMERCs that we see are L4396 and L4397, which are night splints. Now, I've come across a lot of people who are using the incorrect night splint code. We used to always use the only code, which was L4396. Medicare has now designated two separate codes. One to be used if you're just grabbing it off the shelf and dispensing it to the patient. The other to be used if somehow you are modifying that night splint, bending it, shaping it, whatever you document. The proper code for off the shelf is no longer 4396. It's L4397. The L4396 means you're modifying it. So please keep that in mind. That kind of slipped by a lot of us, and you're using the wrong code. L1902, 1906, 1971, these are your ankle braces for ankle instability. Again, know your LCDs. Your LCDs are available through Medicare. That should be the foundation of the actual templates you have constructed in TrackNet, so that with a single click, your LCD is being used for the documentation. You have to have the words like ankle joint instability, muscle weakness, etc. L4360, the typical cam walkers, and L1940, the ankle foot orthoses. These are the most common durable medical codes that we're seeing. Next, Alan. So this screenshot shows the L4396 being used, which is the night splint for the diagnosis of plantar fasciitis as well as pain in the right foot. But notice there's an office visit as well. You absolutely can bill an office visit, which is the evaluation that led to the decision to dispense a durable medical equipment. Again, notice the RT modifier and the KX modifier, since this is a Medicare patient. Next slide, Alan.
John, real quick before we jump on to the next slide, a question came in about something that I actually want to answer real quick. They asked about coding as it pertains to MIPS more than anything else. Mm-hmm. So one of the things that I want everybody to realize is that TrackNet now has become very intuitive and knows when you bill for certain codes, whether it's at-risk foot care codes, whether it's E&M coding, whether it's for DME coding or surgical coding. TrackNet knows based on whatever the code is and the patient's age whether or not you need to collect the quality measures data for those claims. Now, that leads me to one other quick point. I want to just go on a quick tangent. John and I conduct quarterly calls with each and every one of you. I've sent out several emails to you requesting that you get back to me to schedule a quarterly call. This is something that we discuss on our call, collecting the MIPS data from you. This is something that, as TrackNet professional billing clients, that I monitor for you to make sure that you are collecting this data correctly, that you are getting everything that you need. If you have any deficiencies, that we can help you through those deficiencies to make sure you're charting and collecting the data correctly on the quality measures tab within your invoice. So it's very important for you to schedule these quarterly calls with both John and I. And last but not least, as it pertains to MIPS, our next monthly webinar next month will be on MIPS, things that we are doing in 2017 that affects 2019, and even what is coming down the pike in 2018. So before you know it, the calendar is going to turn and we're going to have some new rules as it pertains to MIPS. So please make sure that you all register for next month's webinar, where we will go over what's going on still to finish up 2017 and to get into 2018 as it pertains to MIPS. John, any other thoughts on that before we go on to the next slide?
No, I think, Alan, we're pretty much done covering the common things we see at the billing department. And speaking of registering for that next webinar, there is the schedule of events. Again, this has been sent to you, and we'll show you where you can get this very shortly. But you see that the next webinar on October 4th is setting yourself up for MIPS, just as Alan explained. So you could register in advance for all of these webinars if you wish. Just some subtle reminders. Make sure you're committing to those weekly calls with your biller. Your biller is there to speak to you weekly to review any claims, any issues that you're having. Next slide, Alan. And Alan already talked about these quarterly consult calls. Take advantage of the fact that included as the value, one of the value propositions of outsourcing your billing to TrackNet Professional Billing is that you have consultants at your disposal who are monitoring your practice, can show you trends of your practice, can point out your practice's strengths and possible missed opportunities at the same time. So get those consult calls scheduled with both Alan and I. Next slide, Alan. This is how you get the webinar recordings. We're going to make sure this slide deck is sent out to all of you, and you'll have this link, so don't bother writing this down. You'll have this link available. Next, I think the next slide is our last one. Alan, I can no longer see the questions. Did we address them all?
We did. There's nothing else that had come in other than the ones that I addressed with you a few minutes ago.
Very good.
So,
very good. So that's our time for tonight. We again look forward to next month. A few of our clients who happen to be on this call right now are from Florida. So please be safe. We know what's heading your way. Our thoughts are with you. Please be safe.
Thank you again,
Alan,
everybody.
any comments?
No, thank you again, and I just want to reiterate to please be safe. If there's anything that we can do to assist, please reach out to TrackNet, to John, or myself, and we'll be more than happy to do what we can to assist you in any way we can. But with that note, thanks for joining us tonight, John. Be safe in Las Vegas at your conference, and with that, we'll be adjourned, and we'll look forward
to
seeing
everyone.
We'll get everyone on next month's webinar. Thank you, everyone. Good night.